Hi, everyone. Thanks for joining. We will get started at 5 minutes past the hour to just give a few minutes for others to join. So just hang tight for a few moments. For those of you who are just joining, just go ahead and hang out for a couple more moments. We're going to get started at 5 minutes past the hour. All right, let's get started. Hello, everyone. Welcome to Anatomy IT's overview of the 2026 MIPS final rule. Thank you so much for joining us. My name is Sarah Hakim, and I am the Director of Health Policy here at Anatomy IT. I will be doing a quick overview of the major program changes affecting MIPS reporting for the 2026 performance year. But before we dive into those changes, just a few quick notes. First, the webinar is being recorded, and that recording will be sent to everyone's emails in the next few days, so keep an eye out for that. Second, if you have questions throughout the presentation, please use the Q&A feature. In Teams, we will keep an eye on that and save all questions for the end. We'll also be doing a live Q&A at the end of the presentation where you'll have the chance to unmute and ask questions, or of course, you can continue to ask via the Q&A feature. We ask that you refrain from using the chat since we are going to be putting helpful links throughout the presentation, and we just want to make sure that those links are easy to access for everyone and don't get lost in chat messages. So once again, please use the Q&A feature for any questions. And the last note before we get started is that we have a new business development team to help with inquiries about Anatomy IT's MIPS services. So we're just going to take a moment and have them introduce themselves. So I'll pass it off to Adam to do a quick intro.
Hi, thanks, Sarah. I'm Adam Lafayette, and I am actually in Georgia, but we are part of the business development team along with Jane and Tim. We manage the United States, so if any questions arise from you throughout this, feel free to take these numbers and emails down so that you can contact us. We're more than happy to speak with you about anything regarding MIPS. So thank you very much, and hope this turns out well. Thanks.
Thank you so much, Adam. Again, if you're interested in our MIPS services, feel free to reach out to Adam, Jane, or Tim. And now, without further ado, let's get into MIPS. So here's what we're going to cover today. We'll do a brief overview of what MIPS is and what MIPS value pathways look like, just to make sure that we are all on the same page. Then we'll do a deeper dive into the categories, starting with cost, then moving to promoting interoperability, or PI, improvement activities, or IA, and ending with quality. And then we will have some time for Q&A as promised. So let's start with a quick overview of the basics. When we say MIPS, what do we mean? Where does that come from? So we are talking about the Quality Payment Program, or the QPP, which came about through the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. Now, MACRA was a great law in some ways because it got rid of the Sustainable Growth Rate Formula, or the SGR, which was responsible for Congress needing to pass doc fixes every year to prevent major cuts to provider reimbursement under Medicare. And without those doc fixes, providers would have seen huge cuts, 20 or 30% cuts to their Medicare payments. So MACRA ended the SGR, which was great. However, MACRA also directed CMS to create the Quality Payment Program, or the QPP, which was put into place in 2017. There are two ways to participate in the QPP. One is through Advanced Alternative Payment Models, or advanced APMs. Advanced APMs require clinicians to take on significant financial risk. Most providers do not participate in advanced APMs. Most people fall under the MIPS track, which is the fee-for-service track of the QPP. And that is what we're going to spend today talking about. So why is it important to meet MIPS requirements? Well, the MIPS score that you receive impacts the amount of money that you are reimbursed for Medicare Part B physician services. So if you get a score of 75 points, which is called the threshold to avoid a penalty, that's neutral. So you don't get a bonus or a penalty. Your reimbursement does not receive an adjustment. If you get a score below 75 points, you receive a negative payment adjustment, or a penalty, and that is determined on a linear sliding scale. So the worse that you do, the higher the penalty, up to a negative 9% penalty. If you get a score above 75 points, you receive a positive payment adjustment, or a bonus. This is also determined on a linear sliding scale, so the better that you do, the more you get. However, the funds for the bonuses come from the clinicians who received penalties. So how much of a bonus you actually get depends not only on how well you do, but also on how poorly everyone else does. And the reason for that is MIPS is required to be a budget neutral program. So the funds for the bonuses come out of the pool of penalty monies. And all of this, everything I've talked about so far is the same as last year. There are no changes to payment adjustments, the way that those are determined in 2026. Now, if we look at scoring under traditional MIPS, your MIPS score is calculated by weighting each of the 4 category scores and adding them up. The quality and the cost categories are each worth 30% of the total MIPS score. And these weights were determined by law through the Bipartisan Budget Act. So unless there is some sort of congressional action taken to change the weights of the cost and quality categories, those are going to stay the same in the foreseeable future. Promoting interoperability, which is the EHR category of MIPS, is worth 25%. And the improvement activities category is worth 15% of your MIPS score. And those weights are also unchanged from last year. So that was a very quick review of MIPS. Now we are going to jump into MVPs. So what are MVPs? Sadly, this acronym does not stand for most valuable players. Instead, MVP stands for MIPS Value Pathway. This is an alternative reporting option that CMS introduced that is more specialty or condition focused. So CMS introduced MVPs in 2023, and the rationale behind it is that they aim to simplify or streamline MIPS. So CMS's intent was to reduce reporting burden for clinicians and to help patients be better able to compare data between providers. When you're reporting MVPs, the biggest difference that you'll see is that instead of choosing from the entire MIPS inventory of measures and activities, you are much more limited. You are limited to the specific set of measures and activities that are in the MVP that you are reporting. So we're going to take a look in a few moments at the MVPs for ophthalmology and dermatology, so you'll be able to see some examples of what those look like. But if we compare category by category, starting with quality, in traditional MIPS, you must report 6 measures. At least one of those has to be outcome or high priority, and the preference is for outcome. You can choose from the entire inventory of MIPS and QCDR measures. So that is hundreds of measures. However, if you are reporting an MVP, you report 4 measures instead of 6. Similar to MIPS, you report 1 outcome or high priority measure, but you can only choose from the quality measures that are included in that MVP. So, like I said, it is a much more limited selection. Now, one other big difference with MVPs for quality is that your quality score includes a population health measure. And you can think of these like the administrative claims measures in traditional MIPS. So essentially, CMS will automatically score you on all of the population health measures that are available if you meet the case minimum, and will assign you the highest scoring one. If you don't meet the case minimum for any of the population health measures, then you're just not scored on it. So that component just gets taken out of the numerator and denominator of your quality score as though that measure did not exist and was being suppressed. Now, with the cost category, that is almost the same for both traditional MIPS and MVPs. Either way, you are not submitting any extra data. You're just automatically scored based on the claims that you submit. However, in traditional MIPS, you can get picked up on any cost measure for which you exceed the case minimum. For MVPs, you would only get picked up if the cost measure is included in the MVP that you are reporting. For improvement activities, or IA, under traditional MIPS, you report 2 IAs unless you qualify for one of the special statuses that are listed here. So if you have a small practice designation, if you're a rural practice in a health professional shortage area or non-patient facing, you only need to report one improvement activity. And once again, for MIPS, you can choose from any of the IAs in the MIPS program. Under MVP, so MVP counts as a bit of a special status here. So you also only need to report one improvement activity, but you are limited to the activities that are included in the MVP that you are reporting. Promoting interoperability, or the PI category, is exactly the same for both traditional MIPS and MVPs. And something I really want to highlight before we move on is that you can report both. So you can report both traditional MIPS and an MVP in the same reporting year. And if you do, CMS will assign you the higher score. Before we look at those MVP examples, there were two important proposals that got finalized regarding MVPs for 2026. So beginning in 2026, multi-specialty groups must divide into subgroups to report MVPs. This is not new. That was something that was previously finalized. We knew that that was coming. What is new is how the specialty status of the group is going to be determined. So previously, CMS was planning on using 2-digit specialty codes on Medicare Part B claims information. They are not going to do that. Instead, groups will attest to their specialty status when they register for MVP reporting. And the reason for this is that CMS recognized that there are limitations to information that they can gain from claims. You cannot always get an accurate picture of the type of care being provided just based on looking at claims. So, for example, if CMS had not finalized this new policy, and if they were only going to look at claims information for a group that was employing both ophthalmologists and optometrists, that group would be categorized as multi-specialty, which really isn't accurate because they're both focused on the same type of care. So instead, having clinicians attest to being single specialty during registration will remedy this issue. The other major change is that small multi-specialty practices are exempt from the subgrouping requirement. So if you're a small practice and you're multi-specialty, you don't need to divide into subgroups. CMS says that having small practices divide doesn't really provide meaningful information. So during registration, you would just attest to being a small multi-specialty practice. Okay, so let's take a look at some MVP examples. The ophthalmic MVP, called Complete Ophthalmologic Care, was introduced in last year's rule. So this was available to report for the first time in 2025. This is a list of all of the quality measures included in the MVP. These measures are color-coded based on the key in the upper right-hand corner. Measures that are not benchmarked are in teal. Topped out measures are in orange, and 7-point cap measures are in red. When a measure is topped out, it means that the average performance rate on that measure is 95% or higher. And once a measure has been topped out for 2 years in a row, it gets a 7-point cap, meaning that you cannot score higher than 7 out of 10 points on that measure. And this color coding that I've done here, this is based on the benchmarks file for 2025. We won't have the 2026 benchmarks usually until January or even February of next year. And as you can see, this is a much more limited set of quality measures than if you were to report through traditional MIPS. However, believe it or not, this actually looks much better than when the MVP was first developed. It has come a long way through advocacy efforts. If you practice ophthalmology, we really encourage you to consider reporting this MVP because while it is optional right now to report MVPs, it's not always going to be optional. And as I mentioned before, CMS will award you the higher of the two scores between traditional MIPS and MVPs. So there really is no downside to reporting it. In fact, it will actually give you a chance to test out MVPs before they begin to impact your reimbursements and provide feedback to CMS on what works or what you would like to be different. And later in this presentation, I will go over exactly how you can give this feedback to CMS. Now, the only cost measure in this MVP is the cataract cost measure. So even if you met the case minimum for something else, for another measure, you wouldn't be scored on it. You only have the opportunity to be scored on cataract. Down in the bottom right-hand corner, we have listed the changes for 2026 for this specific MVP. And those changes really just align with changes across MIPS. So the screening for social drivers of health was removed for all of MIPS. And same with those two improvement activities, food insecurity and nutrition risk, and the vaccine achievement for practice staff. Those were also removed for everyone. Here is the dermatologic care MVP. Same format and color coding as before. For this one, the only cost measure is the melanoma resection cost measure. There are a few more changes for the derm MVP in 2026. So CMS added 2 quality measures. Those are the ones that are highlighted in green. It might be tricky to see the color coding because of the highlight, but advanced care plan is 7-point capped for both collection types. And then use of high-risk meds in older adults is topped out. CMS also removed 4 quality measures from this MVP. One of these, the screening for social drivers of health, as I mentioned, is being removed for all of MIPS. However, CMS is also removing from this MVP specifically measure 130, the documentation of current meds, and then 2 QCDR measures, the AAD 17 and 18. And then the vaccine achievement for practice staff is also being removed. So I know it's looking very limited and there isn't a lot of choice for measures when it comes to reporting this MVP. However, like I said, with the ophthalmology one, we really do encourage it if you're in derm because it's the only way that you will be able to test it out and provide feedback to CMS before MVPs become mandatory, and they will become mandatory eventually. So CMS has repeatedly expressed the intention of moving to only MVPs in the future. I took this graphic directly from the Quality Payment Program website. In last year's proposed rule, there was a request for feedback on making MVPs mandatory as early as 2029, and CMS referenced that intent again in this year's rule. So MVPs are definitely coming, possibly in the near future, and at some point, MIPS, as we're reporting it now, will go away. So this is our chance to give feedback to CMS on what works and what doesn't, and what improvements we would like them, we'd like to see them make to MVPs. So when I go over later in the presentation on how to comment on proposed policies and give your feedback to CMS, I really encourage you to take note because that's the only way that we can really make our voice heard and influence policies that we like or those that we're unhappy with. Okay, now I know that this is what you've all been waiting for, on to 2026 MIPS. So let's get started with the cost category. Here are some cost category basics. It is a full year performance period. It is worth 30% of your MIPS score. And the maximum number of points that you can get for cost depends on which measures you meet the case minimum for. So if you only meet the case minimum for the cataract cost measure, for example, then your entire cost category score would be out of 10 because each measure is worth 10 points. You can also get up to a 1% bonus on your cost score if you improved from the year before. And cost is scored in real time, but we won't know the score, the cost score, until MIPS final scores are released. And this is just because of CMS's capabilities right now, so they can't immediately provide feedback. But there are certain cost trends that we've noticed for certain measures that we are able to share with our clients. So if you are interested, we might be able to help you improve your cost score by looking at your data. And for cost, you are not submitting any extra data. It is just based on your claims that you are already submitting. Something that is brand new starting in 2026 is the testing period for new cost measures. So when CMS introduces a cost measure into the MIPS program, it will go through a 2-year informational feedback period. So this means that for the first 2 years, the measure is not going to impact your MIPS score or payment adjustment. You will still get feedback from CMS on the measure as if you were being scored, but it's not going to actually impact you. And this is great. This is something that we have been asking for in our comments. It really will give clinicians the chance to prepare for upcoming measures, and very importantly, will give time to evaluate and refine new measures before they start impacting scores and payment adjustments. So you will actually be able to see firsthand whether you'll be picked up on a new measure and provide feedback to CMS on any changes that you want to see. There are no new cost measures in 2026, but we really expect to benefit from this new policy in future years. So that is great. Another big change in the cost category is the way that the total per capita cost, or the TPCC measure, is attributed. So TPCC aims to measure the overall cost of a patient's care with a focus on primary care. There are exclusions for specialties, including ophthalmology and dermatology. However, with the way that the measure is set up currently, advanced practice non-physician practitioners, I know that is a mouthful, but those are essentially NPs or PAs, et cetera, they are not excluded from the measure. So what we were seeing happening with our clients was that specialty practices that are not providing primary care that would have otherwise have been excluded from this measure were still being picked up on it just because they were employing NPs or PAs. So, for example, an ophthalmology practice might be employing a PA specifically for eye care, and they would still get picked up on the TPCC measure. And this is because the NP or the PA was classified as primary care on claims. So to remedy this issue, starting in 2026, these non-physician practitioners will be excluded as long as all other clinicians in the group are excluded based on specialty. So in that ophthalmology practice example, if all the physicians are excluded, the PA would also be excluded. And this will reduce the likelihood of specialty groups being inappropriately attributed the TPCC measure because they're really not providing primary care. So they really should not have been picked up on this measure. Okay, that is it for cost. There were no substantive changes to existing cost measures and no new measures or removals. So we are going to keep moving forward and move on to the promoting interoperability, or the PI category. Some PI basics. It is a 180 consecutive day reporting period. You can choose the 180-day period that you want to use in the year. You must be on a certified EHR. You can earn up to 100 points in this category. There are 105 possible points because there are some bonus measures, but you can't actually earn more than 100 points, so there is no extra credits. And the PI category is a bit different because it has a mix of attestations and performance rate measures. So to get any score in the PI category, you must submit yes the attestation measures or statements or take an applicable exclusion. For the performance rate measures, you must have a numerator of at least 1 or be claiming an exclusion. If you have a 0 in the numerator for one of the performance rate measures and you are not claiming an exclusion, you will get a 0 for the entire PI category, even if you submitted everything else that you were supposed to submit. And I'm really emphasizing this because I don't want anyone to get a 0 in the category just because of one measure. So really pay attention to this and make sure that you have all of the PI measures completed. And PI is worth 25% of your overall MIPS score. So these are the measures for 2026. The only change to the measure inventory is that CMS added a new bonus measure that's down there in the green, the public health reporting using TEFCA. I'm not going to go through the PI category measure by measure, but if you have reported PI before, this should look pretty familiar and not a huge change, just that one bonus measure. One measure that I am going to talk about a bit is the electronic case reporting measure, or the ECR measure. So this is a required measure in PI that looks at whether you are in active engagement with a public health agency to electronically submit case reporting of your state's reportable diseases. So every state has its own list of reportable diseases. And we actually have a blog on state-by-state reporting, and that goes into much more detail on this measure. We'll go ahead and drop that link in the chat. So if you want more details on how the measure works specifically, that will really help you. But in a nutshell, to satisfy the measure, you need to either test option 1, which is that you're in the process of getting set up with the public health agency to report data to them, or option 2, which is that you are fully integrated and you're already submitting data to them. You can only remain in option 1 for one performance period. So normally this would mean that if you were in option 1 in 2024, you would have to progress to option 2 by the last day of your PI performance period in 2025. However, the reason that I am bringing all of this up is because for the 2025 performance year, that is this year, not 2026, the measure is being suppressed. And this is because the CDC paused onboarding new healthcare organizations, and this made it very difficult to move to option 2 this year. But this is very important. Even though the measure is suppressed, you still need to report it to receive credit. Regardless of whether you attest yes or no or take an exclusion for the measure, you will get full credit this year. But you have to report it because that signifies to CMS that you intended to report the measure. So you must report the ECR measure even though it is suppressed. And again, this is for this year for 2025, not for 2026. Now, along with the measures for PI, there are certain attestation statements that you must attest yes to in order to get a score at all for the PI category. You don't get a score out of points for these, but if you don't attest yes, then you just get a 0 in PI altogether. So there were 2 changes to these attestation statements for 2026. First, you must attest yes to using the 2025 high priority safer guides. So currently only the 2016 version is required, but CMS is updating that to 2025. Do keep an eye on our Anatomy IT MIPS blog because we're going to do a deeper dive on the 2025 safer guides in the future. And for the safer guide attestation, you can fill that out at any point during the year. It does not have to be during your 180-day PI performance period. The second change to the attestations was with the security risk analysis, or the SRA. So currently, you just need to attest yes to doing the SRA, But starting next year, there's also going to be a second component to this attestation where you also need to attest yes to implementing security measures, not just doing the analysis. So it's becoming a little bit more involved. Like the safer guides, that can be done at any point during the year. Now, I want to direct you back to the second attestation statement, the one that says actions to limit or restrict interoperability of CERT. This is essentially attesting that you have not engaged in information blocking. And I kept the slide here as a reminder. Nothing has changed, but last year, the disincentives for information blocking for healthcare providers became effective. And under this policy, if you are found to have engaged in information blocking, you will get a 0 in the PI category, and you will also get your information posted publicly on the ASTP, or the Assistant Secretary for Technology Policies website, along with your business address and how you information blocked. I'm not going to go into a lot of detail on this, but I wanted to bring it to your attention. There are a lot of intricacies with this policy in particular in terms of how claims are investigated and how the information blocking disincentive is applied to groups. And we just don't have time to go into all of that. But I do recommend that you take a look at our blog on this. We'll drop that link in the chat as well. And in that, we also go over the basics of what information blocking is so that you have everything you need. The last thing I want to mention in PI before we move on is going back to that security risk analysis attestation. I want to just emphasize that this is a requirement not just under MIPS, but under HIPAA. It's really important. That is why CMS is making the SRA attestation more robust next year with the additional attestation, the requirement to implement security measures along with the analysis. In the SRA, you can do it with us or you can do it on your own. If you do it with us, we have a whole separate division at Anatomy IT doing HIPAA that can help you, and you can bundle it with our other MIPS services. And we can also help you with the safer guide requirement. So let us know. We'll have a contact email at the end of the presentation so you can reach out if you are interested. If you do the SRA on your own, just make sure that you are doing a thorough deep dive into this. A common misconception is that it only includes technology, but there are also physical and administrative safeguard categories. So, for example, are your office doors locked, or do you have privacy shields on your computers? So things like that. It is a lot more involved than just looking at the technology element. So I just wanted to bring that to your attention as well. Okay, so moving on to improvement activities. This is a 90 consecutive day performance period. And as with PI, you can choose the 90-day period that you want to use. You can earn up to 40 points in this category, and you just need to pick enough IAs to hit 40 points. So in general, each improvement activity is 20 points. So most providers need to do 2 IAs to get full credit. But if you have one of the listed special statuses, you get double credit for each IA. So you only need to do 1. So that is if you are a small practice, if you're rural, non-patient facing, or in a health professional shortage area. You also get double credit if you are reporting an IA and an MVP. So you also would only have to do 1. And the IA category is worth 15% of your final score. So looking at the changes, there are quite a few changes for the IA category, namely a lot of removals of activities. CMS got rid of the Achieving Health Equity, or the AHE subcategory. So the IAs in this subcategory were either removed or assigned to other subcategories. And the new subcategory that they introduced was called Advancing Health and Wellness. There were also 3 new improvement activities introduced, including one on patient safety and the use of AI. So very relevant. The modifications were primarily measure ID changes, reassigning IAs that were previously in the Achieving Health Equity subcategory to other subcategories. So there isn't really a lot that was modified. But then there are 8 IAs that were removed altogether from MIPS. And these are the same IAs that were suspended in the middle of this year. So we have those listed on the slide. So those are the things that were finalized in the 2026 final rule, but I also wanted to highlight some changes that were finalized in last year's rule, but are going to now become effective in 2026. So one of these is the modification of the patient portal measure. Starting in 2026, you will only be able to attest to this improvement activity if you're using a new patient portal. So it won't be applicable if you just have an existing portal. There are also 4 more removals, and those include the closing the referral loop IA and the more timely communication of test results. Those are pretty common ones that we had used, so I just want to make sure that you're aware that those won't be there next year. So that's it for IA. That was pretty short. Last but not least, we have the quality category. Quality is a full year performance period, just like cost. You can earn up to 60 points within this category. You do that by submitting at least 6 measures, one of which must be an outcome measure or high priority measure. Quality is worth 30% of your MIPS final score. And there are also bonus points. So small practices, that's 15 or fewer clinicians, can get 6 points. You can also get up to 6 points for improving on quality measures from the previous year. And the way that works is you will get 1 additional point per measure, up to 6. And the way that you report quality, you can report quality through a registry or a QCDR, those top 2 ones. Those are the most common ways. You can do a direct upload, but that is a lot more cumbersome. The files need to be in a specific format. So it is a lot easier to do the registry or QCDR option. And then the claims method is only applicable if you are a small practice. If we take a look at some general information on quality submission and scoring, so you will get anywhere from 1 to 10 points for a quality measure if it has a benchmark. If you meet the case minimum of 20 after accounting for exclusions and exceptions, and if you meet data completeness, which is 75%. So that means that you have to submit data for 75% of all denominator eligible patients for that measure. So what happens if a measure doesn't have a benchmark or if you don't meet data completeness? Small practices will still get 3 points for that. Large practices will get 0 points. So if you remember, you are required to report 6 measures, but there is no downside to reporting more than 6. And in fact, we recommend it because the more people that report on measures, the more likely they are to get benchmarked. And CMS also uses your highest scoring measures for the category score. So there really isn't a downside. That is something to consider, that reporting additional measures can also increase your chances of doing well in quality. For data completeness, it is still at 75% through 2028. And for measures that are new to MIPS, there are special benchmarks. So measures in the first year get a 7-point floor. Measures in their second year get a 5-point floor. And then this last part here in the bottom right-hand corner, I alluded to this bit when I encouraged that you should report more than 6 measures, and it's really for this reason. If CMS gets at least 20 submissions for a non-benchmark measure and all of those submissions meet the case minimum, then that measure can actually get a live benchmark for the current performance year. And then you can earn up to 10 points instead of 0, which is what it would be if it was a non-benchmarked measure. All right, so looking at quality changes for 2026, CMS removed health equity from the definition of a high priority measure. That is pretty consistent with other changes that they have made throughout MIPS. You saw that they removed the achieving health equity subcategory from improvement activities. In terms of measures, there are 5 new measures, 10 measure removals, and 30 measures that have substantive changes. We'll go over some of those in a bit. And then the flat benchmark scoring system for some topped-out measures specialty measure sets with limited measure choice and a high proportion of topped-out measures. What is new is that CMS is also going to apply the scoring system to those same measures that are in MVPs as well. And then CMS added a few new measures to the set that is scored this way. And that does include 1 ophthalmic and 2 orthopedic measures. So measure 141, for that one, it is just the Medicare Part B claims collection type. So not applicable to everyone. Okay, so we're going to do a review of the top measure changes. We're going to dive into the weeds a bit and take a look at some of the top measure changes that are relevant to our client specialties. Starting with dermatology and plastics, there was just one big measure change, and it was for measure 176. CMS added some new medications to the denominator. I am not going to read all of those out, but go ahead and take a look at the slide. CMS also revised the language in the denominator instructions to clarify that the medication list for this measure is not exhaustive. So any medication requiring TB testing prior to treatment should be included. For ophthalmology and optometry, starting with measure 12, the POEG optic nerve eval, CMS revised the language in the measure description and numerator to during the measurement period. Before it was within 12 months, so more of a clarification there. For measure 117, diabetes eye exam, so CMS proposed removing the MIPS CQM collection type. However, they listened to public comments that said, no, don't do that, and chose to keep it to support smaller and rural practices. So I wanted to point that out because it's a great example of how speaking up can make a difference in policy. The other updates to this measure are the denominator exclusion update to exclude patients missing both eyes and the numerator revision, which allows for an autonomous eye exam to meet the requirement. For measure 141, the update for this measure is going to become effective in 2027, and that is that they're going to update the time frame for documenting the plan of care to within 7 days after the patient encounter when IOP was assessed. And the reason for that delay is because CMS did not clearly state that change in the proposed rule, so it wouldn't be fair to have it go into effect in 2026. For measure 191, CMS updated the denominator exclusion to include the list of diagnoses that qualify as significant ocular conditions. There are some more changes for ophthalmology as well. So for measure 389, there was an update to the numerator note. CMS added that it would be expected that the planned or target refraction be assessed and documented within 90 days prior to the denominator eligible procedure. And CMS did clarify that it does also include the day of the procedure, so 90 days prior and the day of. Measure 419, overuse of imaging for the evaluation of primary headache. Unfortunately, this measure was removed. We did have quite a few clients using this one, so it is disappointing that it is no longer available. And then measures 500 and 501, the acute PVD measures, same update for both of those, that CMS updated the measure submission frequency to once per performance period. So that is it for ophthalmology and optometry. Next, we have orthopedics and podiatry. For measure 357, surgical site infection, CMS updated the instructions. Essentially, you need to evaluate all sites of the procedures, and if more than one surgical site infection is observed, you would assign the one at the deepest level that occurs within a 30-day post-op timeframe. For Measure 376, CMS updated the denominator exclusion to exclude patients with one or more specific lower body fractures indicating trauma in the 48 hours before or at the start of the total hip arthroplasty. And then for Measure 418, this is the one measure on this slide that can also be used for podiatry, osteoporosis management in women who had a fracture. So CMS just revised the list of tests for measuring bone mineral density, and they removed 2 of those tests, so they can no longer be used to meet performance. And then Measure 480, this is one of the administrative claims measures. CMS updated the denominator exclusion to remove the COVID exclusion. For physical and occupational therapy, there was only one relevant measure change, and that is to Measure 281. CMS just clarified that the timing of the routine assessment and review of results must be at least once within the 12 months preceding a dementia encounter during the measurement period. And then for otolaryngology, there's also just one relevant measure change, 419, the overuse of imaging for evaluation of primary headache, which, as I mentioned earlier, unfortunately, this measure was removed from MIPS. CMS just felt that this the action being measured had become a standard of care, and that they just felt that there was no more meaningful room for improvement. That is why they decided to remove it. There were a lot of general measure updates as well. I'm not going to go through all of them, but the measures are listed here on the slide, and I highly encourage you to look at our MIPS 2026 top final changes report for the details. So we will put that link in the chat as well. I know that this is a lot just going through measure by measure. So if any of the measures that we talked about are relevant to you, please do take a look at that top changes report. You might find it's a little bit easier to digest than just listening. Okay, we have one more slide before we get to the Q&A. I know we're running up a little bit on time, but I just want to go through this quickly. I mentioned this a few different times throughout the presentation, that there is a way for you to influence MIPS policies, and you can actually tell CMS what works, what doesn't, and what changes you would like to see. And that is done through the regulatory process. So how does the process work? First, Congress passes statute. And in this case, if you remember from earlier, that law is called MACRA. And that is the law that directed CMS to create the quality payment program. That sets off the rulemaking cycle. And in this case, the rule comes out every year. There is a proposed rule. And for MIPS, that usually comes out in July. Once that proposed rule is released, there is a public comment period. And during that time, anyone can comment or provide feedback on what is in the proposal. You can also comment on aspects of the program that are not in the proposal, but CMS is not going to change anything that year that they didn't propose. So if you do, they will still read your comments and keep that information for future rulemaking. For the MIPS rule, the comment period is 60 days. And then CMS reviews the comments and puts out the final rule. And for MIPS, that's usually the beginning of November. And once again, the biggest thing I want to emphasize here is that the more voices that comment on an aspect of policy, the more likely it is that it will change. So for all of the things that I went over today, the MVPs, the quality measure changes, the improvement activity removals, whatever it is that you want to see changed, you can let CMS know, and we encourage you to do it. Anatomy IT submits comments every year. If you're interested in seeing what we write, keep up with our blog, and we even include a template letter on there that you can use when you're submitting comments to CMS. So I know that this is not the most fun thing to do, but it is really important if we want to see positive changes to this program that really does impact you. Okay, I know we just have 5 minutes left, but we are going to open it up for some Q&A. So go ahead and use the question and answer feature, or go ahead and raise your hand and we'll unmute you. Okay, so I did see one question come in about the attestation for specialty status for MVPs. So the question was, do I need to attest to being in a multi-specialty group? So let me go back to our MVP section. So this was the change that we had. So yes, do you need to attest to being in a multi-specialty group? And the answer is no. So during registration, you would attest to being in either a single specialty group or a multi-specialty small practice. So if you are in a large multi-specialty group, you will not attest to anything. You would just have to divide into subgroups to report. So the attestation is more to say that you're more of a way to say why you're not dividing into subgroups. So either because you are a single specialty or because you are a small multi-specialty practice and you're exempt from the requirement. So to answer the question, do I need to attest to being in a multi-specialty group? Only if you are a small practice. Let's see. Okay, so another question that we had come in, will the change to the TPCC measure improve my cost score? Let's go back to that. Okay, so the answer is that it depends. So remember, for cost, the number of points that you can earn depends on what measures you get picked up on. So what this change to the TPCC attribution is doing is it's making it less likely for you to get picked up on TPCC if you really aren't providing primary care. So whether your cost score improves depends on how well you were doing on TPCC, if you were getting picked up on it, what other measures you're getting scored on, and how well you do on those measures. So, for example, if historically you've always been getting picked up on cataract cost and total per capita cost, and you've been doing really well on cataract, but you've been doing poorly on TPCC, you should see your score improve. But if you do poorly on cataract and you're not being scored on TPCC anymore, now your cataract cost measure is accounting for all of your cost score. So it's possible then in that case, you would probably see your score decrease. And then I see a question here in the chat. Would the quality measures need to represent 75% of providers reporting? That was a great question. Let's go back to the quality scoring slide. Okay, so where that 75%, where you're getting that from is probably from here, from the data completeness. So the answer is no. So the 75% is the amount of data, the percentage of the data that you need to report of the denominator eligible patients. So if you look at, if you have a cost measure and that cost measure is measuring something on, adults up to age 65, then all of the adults up to age 65 that you're seeing, of all of those, you would have to report on 70% of that population. So the 75% data completeness is not for the providers, it is for the population that you were seeing in that measure, so the patients. But that was a great question. Okay, we are up on time. I know we didn't have a ton of time for questions. I see one in review asking about whether a recording will be sent out. Yes, it will. The recording will be sent out in a few days, so keep an eye out on that. But we are going to drop off there. Let me just pull up our final slide. Thank you all so much for attending. I know it was a lot of information, but we really appreciate your attention and the great questions. And we have our MIPS Connect email up there. If you are interested in any of our services or if you have other questions, please feel free to reach out. Thank you so much. And again, do take a look at the blog. I see that we have our final rule overview blog posted in the chat as well. Thank you again for your attention. And we will end the webinar.